I am Dr. Swar, consultant endocrinologist from Kolkata. It's my great pleasure to talk to you a novel concept in management of type 2 diabetes mellitus. The evidences indicate that early intervention and achievement of glycemic control reduces the long-term risk of micro and macrovascular complications in type 2 diabetes. UKPDs demonstrated a legacy effect of early intensive therapy because the difference in cardiovascular event rates 10-year post-trial was apparent. Empagliflozin or linagliptin is being considered as an alternative first-line treatment. Initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline HbA1c level. In connection with that, I am now discussing a prototype of case we usually face in our daily practice. So Mr. Ovik, 45-year-old with newly diagnosed with type 2 diabetes, visited clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. Recently, he visited again as part of the routine checkup. His laboratory workup shows that the HbA1c level is 8.5%, eGFR 80 ml per minute, LDL cholesterol 80 mg per dl, HDL 38 mg per dl, triglyceride 200 mg. And the medication he is currently receiving, that is metformin 1 gram twice daily, telmisartan 40 mg once daily, metoprolol 50 mg once daily, atorvastatin 20 mg once daily, aspirin 75 mg once daily. And physical examination reveals a BMI of 31 kg per square meter. So he is obese. And this hypertensive patient, now he has a BP of 120/70, that is under control with a heart rate of 78 beats per minute. Every 1% HbA1c reduction is associated with reduced risk of long-term complications in type 2 diabetes. There is 43% reduced risk of amputation or fatal peripheral vascular diseases, 37% reduced risk of microvascular complications, 12% reduced risk of stroke, 14% reduced risk of myocardial infarction, and 21% reduced risk of diabetes-related death. So it is easily understood how much important is to control glycemic status. And early combination therapy in type 2 diabetes makes the critical sense for several reasons. First, a meta-analysis demonstrates that early use of combination therapy significantly increases the likelihood of achieving glycemic target of HbA1c less than 7% compared with metformin monotherapy. And for patients with HbA1c value more than 1.5% above goal at diagnosis, ADA and ESD guidelines recommend first-line treatment with a dual combination and SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular disease, congestive heart failure, or CKD. Empalina is available as the first-in-class treatment in SGLT2 inhibitor and DE4 inhibitor combination group of drugs. SGLT2 inhibitor is a class of novel oral glucose-lowering agents that mediates glucose-lowering action by increasing urinary glucose excretion via inhibition of sodium glucose cotransporter 2 in the proximal tubule of kidney. The salutary effects is its ability to act independent of insulin secretion and action and render it suitable to administer at any stages of disease course. DE4 inhibitor exerts its glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose-dependent insulin secretion, and inhibition of glucagon release. Combination of these agents has potential to show the additive glycemic control due to their complementary effects. Empiric outcome reported that 3-point MACE outcome occurred in a significant lower percentage of patients in empagliflozin compared to placebo on top of standard care. In addition, cardiovascular safety of linagliptin DB4 inhibitor was further elucidated in Carmelina and Carolina trial. So, EMPA and LINA combination with complementary mechanism and pleiotropic benefit may be a suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high risk established heart failure or CKD due to tolerability of the combination in addition to potential benefits of empagliflozin on CV and renal outcome, and no increased risk of heart failure with either agents. According to study, early achievement of H1C goal less than 7% with EMPA-LINA could reach target H1C at 12 weeks compared to monotherapies. H1C decrement by EMPA-LINA has demonstrated around 1.8% H1C reduction at H1C baseline of more than 8.5% at 12 weeks, 24 weeks in metformin treated groups, and the benefit of glycemic control were maintained at week 52. And a higher percent of patients achieving H1C target of less than 7% were reported for combination. The combination offers a suitable component in strategy to achieve target H1C without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infection associated with SGLT2 inhibitor has been reported. And when a DB4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanism that remains to be investigated, like DB4 activity is present within some yeasts, molds, and bacteria, and its inhibition may directly modify microorganismal function. This highly specific and sophisticated hypothesis need to be tested experimentally. In summary, EMPA-LINA combination provides robust H1C reduction and 2 to 4 times higher odds of patient reaching the goal H1C compared to individual agents with low hypoglycemic risk. Thank you, everybody, for your patience hearing.